Good afternoon, everyone, and thank you for inviting me to give this presentation. My name is Vesela Kovacheva, and I'm an attending anesthesiologist at Brigham and Women's Hospital, the director of translational medicine at the Division of Obstetric Anesthesiology, and assistant professor at the Harvard Medical School. My research has been funded by the FAIR, APSF, Partners Innovation, Brigham Research Institute, and Connors Center, First in Women Medicine, a precision medicine platform. My disclosure is listed below, and it's not relevant to this talk. So today, we're going to talk about how the artificial intelligence or AI methods can augment patient care. Briefly, we are going to overview the plan for this talk. First, we will start with what is AI and how these models are created. We're going to show a few examples of how AI can aid clinical decision-making. And then we're going to review the limitations and how, using different methods, we can overcome those. So we are convinced that the machine can do better than human anesthesiologists. This article was published in the Washington Post in May 2015. And it was to announce the arrival of a new machine which was called iControl RP anesthesia robot, which could administer closed-loop deep sedation using remifentanil and propofol. Since then, while this robot never made it to the clinic in order to compete with us, the statements of the title are true today in ways that the authors did not even intend at that time. Indeed, it is true that in some cases, AI can do better than the human anesthesiologist, but especially in those tasks that involve very complex repetitive tasks and analyzing a vast amount of data. It is also true that we as human anesthesiologists can perform much better than any machine tasks which require dealing with the unknown, emergencies, abstract and complex thinking. And as a result, no AI will be able to replace us, and certainly not in the near future. But it is a very powerful technology that can augment our skills and help us take better care of our patients. I'm going to show a few examples. So looking at this ECG, can we say what is the ejection fraction? Well, not really. To us, this may look like a normal EF. However, there is an AI model out there that thinks otherwise. In this case, this artificial intelligence model can use the ECG for the detection of asymptomatic left ventricular dysfunction, which is a precursor of heart failure. In this case, the investigators paired a 12-lead ECG and echocardiogram data from 40,000 patients, and they trained a model which is able to identify those patients who have left ventricular dysfunction or ejection fraction less than 35%, which is using only the ECG. And so as a result, this model can detect very subtle signs in or patterns in the ECG, like, for example, the shape of the P wave or the size of the QRS complex, which are invisible for the human eye. And in this way, it can predict quite accurately the ejection fraction. And therefore, sometimes we can use models like this to screen those patients when they receive their routine ECG. Now, what is the hemoglobin of this patient? For us, again, we cannot say just by looking at ECG. However, in this case, it was low, and actually this patient had anemia. So this was another study in which the model was trained to recognize which patients with anemia, which patients had anemia using their hemoglobin, which was obtained within 1 hour of obtaining the ECG. As a result of that, the model very highly accurately can predict which patient has anemia based only on having the ECG. So what should we do right now? For us who have looked at ECG many times, we can simply notice that this ECG was reversed, and just by flipping the image, we'll be able to read it. But for those sophisticated models that I just showed you, it will be unknown. They would try to read this ECG unless they were specifically trained that ECG may be reversed. So in this way, this demonstrates the limitation of these models, that they are very good and very precise at only the tasks for which they are prepared to be done. So now we are going to take a deeper dive into what is AI and how these models can be created. AI, or artificial intelligence, is a wide-ranging branch of computer science which is concerned with building smart machines capable of performing the tasks that typically require human intelligence, such as ability to reason, discover meaning, generalize, or learn past experience. So how do we make an AI model? Well, for our recipe, we need 3 components. Data, we need a lot of that. And this is really the most crucial step for creating those models, because we can deduce or get information only what is available in our initial patient cohort. Next, we need sophisticated tools. And thanks to the incredible development of industry, finance, we have very precise and very sophisticated machine learning tools. We can just apply those to our data. And then we need high-performing computer. To larger extent, the most recent developments in artificial intelligence are due to the availability of widespread availability of high performance computing. So as I said, data preparation is the most crucial step. And when we think about medical data, most common source of this data is the electronic health records. And we can think about the data that is available for any kind of machine learning task by dividing it into 2 kinds of data. Structured data, for example, this is data that is well-defined and pretty standardized. For example, the patient's age or date of birth or their height and weight. And then we have unstructured data, which is pretty much everything else. This is clinical data, imaging data, and one of the greatest utilities and basically the breakthroughs of AI is that it has allowed us to analyze this unstructured data. And this has opened the access to much larger universe of information than previously just the available world of the structured data. And so, as I said, having clean data is the most crucial step. And actually, most of the work in creating the artificial intelligence models is focused at collecting the data and cleaning the data. Once this step is complete, the subsequent steps are much more standard. So how much data do we need to create a machine learning model? Well, it actually depends on the task. If we're trying to predict a really rare event that happens not often, then we're going to need large amounts of data. On the other hand, if our predicted outcome is pretty robust, we may be able to do less. Most of the times, we actually don't know exactly how much data do we need. And most commonly, we start with what we think is going to be sufficient for the model. We create the model and train it, and then look at the performance. And then just like in cooking, we can add a little bit more and see data if the performance is improving. And then if the improvements are very minimal, then most likely this model has reached its peak performance, and adding additional data would not be beneficial. On the other hand, if there is a significant improvement in the performance of the model to better predict the outcome of interest, then adding additional data will be beneficial. And this is an area we should focus our efforts on. So once we are satisfied with the amounts and the quality of data we have, it is time to train our model. For the purposes of the training and to make any model, we have to partition our data into 3 parts. Typically, we take about 70% of the data and we use that for training. We use about 20% of the data for validation. And then we separate the last 10% of the data and put it aside and do not work with it until it is time to assess our model. That is at the very end when we are satisfied with its performance. So how do we train a model? As I said, we start with 70% of the data, and we use the variables that are available. And initially, we randomly assign different weights. And we perform our training, which is basically a process where a mathematical function is assigned to predict a certain outcome. And then we evaluate how well we are able to predict that outcome. Most of the times on the first try, we would not be satisfied with the results. And so we repeat over and over the process of assigning different weights, slightly changing this mathematical function until we are satisfied with the performance of the model, until the predictions that the model arrives are satisfactory for us. And then there is 2 options when the model can achieve satisfactory results. One of them is that it may overfit, which means that the model just learned all the data that we use in the training. And that is the reason why it is performing so well. Or the other reason is what we hope happened was it actually learned an underlying mathematical relationship between the data and is able to apply that to create meaningful predictions. And so to be able to differentiate which of those 2 situations we are in, we use the validation data, which is that 20% of the data that we haven't used so far. And we apply the model to that 20% of data, and we see what the predictions are. And if they are satisfactory, that means that most likely this model is performing well, and then we're moving on to the next step. However, in case that we're not satisfied with the performance, we can take the model back into the training. We can reshuffle the data between the training cohort and the validation cohort. For example, we can move some patients that were previously used to validate now to put them back into the training. And in this way, when we shuffle the data, we can help the model to improve its performance. We may have to repeat this cycle as many times as it's necessary until it becomes satisfactory performing at predicting a certain outcome. And once that is the case, then we are ready to test our model. So we take those 10% of the cases of our patients, of our data, and we need to check how well our model is able to predict unknown outcomes. So we have for example, if we're trying to predict patients with anemia, we know which of our test patients had anemia and which ones didn't. Then we can apply the model to this data set, and we can look at the predictions. If the model predicted that the patient has anemia and the patient indeed has anemia, that is a true positive. And then if the model predicted that it does not have anemia, then that is, and also the patients do not have anemia, then that's true and negative. And then respectively comparing the true positives and the false positive can actually tell us how well the model is able to accomplish the assigned task. And in most of the literature, when we are talking about performance of the models, we use the area under receiver operator characteristic curve, or AUC. Initially, that curve was a method that was originally developed for the operators of military radar receivers, and that was in the year of 1941. Here you can see a picture. And so basically, this is a curve in which we plot the true positive outcomes versus the false positive outcomes. And then we evaluate the area under that curve. So here you can see in gray. And we arrive with a number which is between 0 and 1. The closer that number is to 1, this means the better the performance of the model. And then the closer this, the AUC number is to 0.5, it means that our model is not very good at predicting. It's just as good as a coin toss. And then if it is closer to 0, that means that it's actually predicting something in the opposite direction. So using this AUC and using the test patient group, which we had saved, can help us evaluate how good is our model performing the assigned task. So now, to put everything into perspective, I'm going to describe how these models can actually, once they're created, be integrated in our workflow. For example, if we can imagine that we're working to create a model to predict the patient's risk of postpartum hemorrhage. We're going to start with using a cohort of pregnant patients which have different clinical factors, and most of them would be at low risk for bleeding, but there would be a few that will be at high risk of bleeding. And we are going to enter all the variables that may contribute to that. Usually we select those variables based on our clinical knowledge and also what is available in the data set. The larger the data, the more likely we are to get good predictions. Also, the more diverse the data is, the more it involves different populations relevant to the populations in which we're going to use the model, the better it's going to be, the more useful it will be for us. And then, as I said, we're going to use all these methods to develop the model using up-to-date knowledge and concept. After we're satisfied with the model, we're going to evaluate the predictions and make sure that it performs well in all patients, that there is no racial bias, for example, and that we can apply this to population in which we intend to use it. And then we can incorporate this model, for example, as a part of our electronic health records, so that when the physician admits a patient, their risk for hemorrhage is readily available for us. We can, based on those predictions, we can use our medical knowledge and prepare supplies, cross-match blood, or perhaps even transfer to a tertiary care facility those patients that are at high risk for hemorrhage. And then hopefully by utilizing this approach, we can provide better care for our patients. So this is how we envision that these models can be applied in our clinical practice. And now we're going to look at a number of examples of different models and how they can contribute to our clinical decision-making, how they can allow us to take better care of our patients. Is our patient ready for surgery? This is a question each of us asks every day before we start our case. And the stakes are really high, as up to 43% of the patients will experience postoperative complication. And globally, this is the third most common cause of death after surgery. And so our current risk stratification tools are lacking. Most commonly, we use the ISA classification, which was originally created to predict, which was originally created to help with billing and subsequently, the use of ASA has expanded to predict postoperative complications and even mortality, even though that was not the original intended goal. And here, this figure illustrates that ASA classification is not, it does not have a very good inter-rater agreement, meaning that in this case, for 10,000 patients, the ASA class was assigned when they were seen in the preoperative visit. And then subsequently, another anesthesiologist assigned ASA classification on the day of the surgery. And here you can see that the assessments of those two anesthesiologists vary significantly, sometimes up to 67% between the cases. And so there is a need for better and more accurate predictive tools to help us risk stratify our patients preoperatively. And this is one example of that, in which the investigators aimed to predict postoperative mortality. They started with data from 400,000 surgeries, and eventually they selected 58,000 patients to train their algorithm. And these are some of the variables that were used and the differences between the training and the testing data. And here is shown the performance of the model. So we see the comparison of the created artificial intelligence model here in orange as compared to the ASA status in purple to the Charlson Comorbidity Index. So in orange, the machine learning model had the most significantly improved predictions for postoperative mortality as compared to all other existing models. And the advantage of the current tools is that all the variables that go in a model like that can be used automatically from the electronic health records. And in this way, for example, when the patient is seen in the preoperative clinic, all those variables can be inputted electronically without a need to create extra work. And the model can work behind the scenes, as, for example, as a part of the electronic health record, and generate those predictions, which subsequently can be used by the anesthesiologist and perhaps the surgeon as well to plan a better operative course, maybe laparoscopic versus open surgery for those patients that are at high risk, or for the anesthesiologist to consider alternative technique, for example, regional technique, maybe a better choice for patients at high risk for complications. I'm going to give another example from my practice in obstetric anesthesiology. And in this case, we sought to predict which patients with hypertensive disorders of pregnancy are going to be at high risk for preterm birth. So in this case, our healthcare system has multiple hospitals. And here to the left, you can see the Nantucket Cottage Hospital, which is a small hospital and has very limited resources to take care of a premature neonate. And then in comparison to the right is the Brigham and Women's Hospital, which has very well-equipped neonatal ICU unit. And we designed fully connected deep neural network using that black box model. We used 14 parameters which were readily available on admission. For example, maternal age, history of preeclampsia, blood pressure reading, some of the laboratory values. And we were able to design a model which can accurately predict which patient is at high risk for preterm birth. And using a model like that, anesthesiologist or sometimes obstetrician can predict if their patient is at high risk for preterm delivery and consider, for example, transferring them to another facility which may be better equipped to take care of this newborn. And then, as I said, our model is a black box, which means that we don't quite understand exactly how different variables contribute to the prediction. So I'm going to use another example from cancer diagnosis to explain how can we use transparent models. So in this way, in this case, the model was trained using some cancer images to predict whether the patient has cancer or not cancer when we present an unknown image. However, this model will be accurate in about 96% of the cases, and still in about 4% of the cases, still the predictions of the model may not be accurate. And how can we know when to use the model and when to use our own clinical decision making? So we can use an explainable model in which the model can provide additional information how those predictions are made. And in this case, it can highlight which parts of the image have contributed to the decision making. And using that additional knowledge, the physician can decide whether to accept or reject predictions of the model. Applying those techniques to our model to predict preterm birth, we can highlight which factors for particular patients are actually contributing to the outcome. So here we can see this patient has a very high risk of preterm delivery. And here to the right, we can see what factors of the patient's history contributed to the prediction. And here to the left, we can see what is the relative significance of each of those factors. So having that additional information can help us better determine whether we should follow this model or not. And then another advantage of this approach using transparent methods is that we can actually detect racial bias. So initially, this was here to the left was the performance of our model. And there was about 10% variation in this performance if we compared Black and white patients. And using those transparent methods, we were able to calibrate, adjust our model until it achieved equal performance in all racial groups. In addition, as a result of that, you can see that our accuracy also improved. So using these transparent techniques can actually help us refine, improve our models, detect racial bias, and also help us decide how to use and whether to use these models. In additional application of the artificial intelligence is during intraoperative care. These days, there is a lot of data which is available to the anesthesiologist. We have large amounts of imaging data. We have constant information flow from our monitors. We have the electronic health records, and new diagnostic modalities are available, including genetic data. So using artificial intelligence models can help us integrate this vast amount of data, which sometimes is beyond the comprehension of human mind, especially in the fast-paced intraoperative environment. Being able to process all this information, sometimes in real time, can actually help us provide a very personalized care for our patients so that we can target our anesthetic to meet the needs of that particular patient. For example, we can personalize drug administration for our patients. In this case, there was an artificial intelligence model which was trained to read ECG spectra, and based on EEG spectra, the model is able to determine if the patient is conscious or unconscious. Here you can see that the prediction of the model is very accurate with what the anesthesiologist did, giving higher doses of propofol, and then here the patient was unconscious, which coincides with the EEG spectra. And in this case, this is intraoperative care of the patients. So after the patient was awake, here they received additional propofol. Here they were unconscious, and then in the middle of the surgery there was this period of a slight increase in the EEG spectra, and which resulted into administration of additional doses of propofol. And here we can see that the model actually is able to predict this event slightly earlier. So using models like this, we can personalize the administration of different interoperative medication and achieve more smooth administration of, for example, propofol infusion, and better and safer care for our patients. And additional ways in which the artificial intelligence technologies can add value to patient care and increase patient safety is by providing additional expertise that would otherwise not be available. For example, cardiac ultrasound. In this study, the model was trained to recognize and aid a non-specialist in obtaining and reading cardiac ultrasound images. In this way, the model can provide reasonable guidance even to novice anesthesiologists who are not trained in obtaining cardiac images. So here you can see that this image was not optimal, and the model is telling the provider how to optimize the image. So using this models like this in a low resource setting, or for example, when there's inadequate staffing in the night, can help democratize access to different diagnostic modalities that would otherwise not be available. So in this talk, we saw how artificial intelligence tools can help with better clinical decision making. These models can be applied to virtually all areas of perioperative care. We saw some examples how these models can help with predicting postoperative mortality, risk of complications, risk of preterm birth, how they can help us better plan our anesthetics, as well as provide more smooth intraoperative care, and how we can expand and obtain some new diagnostic modalities which otherwise would not be available. I've demonstrated how some of the limitations may be overcome using transparent and explainable methods. And we're going to finish with a quote from Oren Estioni. AI is just a tool, and the choice about how it gets deployed is ours. I hope that we can use these models to achieve better care of our patients, and these models can help with our clinical decision making. Thank you. I'm going to also thank a lot of people who have helped with my research, the Brigham Anesthesiology Department, Obstetric Anesthesiology Division, a lot of the members in my lab, Raphael Cohen, who has done a lot of the planning and development of those tools, Brigham Innovation, Partners Innovation, and Brigham Research Institute. Thank you, everyone. And this is my email. I look forward to your questions and the live session. Thank you.